My name is Keisha Davis, and I'm writing this from my hospital bed where I'm recovering from emergency surgery that should have happened 8 years ago, but was delayed because multiple doctors dismissed my severe pelvic pain as drug-seeking behavior, low pain tolerance, and dramatic overreaction, typical of what they apparently expected from a black woman in medical distress. At 35, I'm a registered nurse with 15 years of experience in labor and delivery at Methodist Hospital in Houston, where I've dedicated my career to helping other women through childbirth and reproductive health challenges. Yet when I became the patient instead of the caregiver, I discovered that my medical knowledge, professional credentials, and intimate familiarity with hospital systems provided no protection against the racial bias that nearly cost me my life and definitely cost me my fertility, my career stability, and years of unnecessary suffering that no human being should endure. The symptoms began in 2016 when I was 27, starting as severe menstrual cramps that gradually evolved into debilitating pelvic pain that occurred throughout my monthly cycle rather than just during menstruation. The pain was sharp, stabbing, and intense enough to wake me from sleep, cause me to vomit during particularly severe episodes, and interfere with my ability to work 12-hour nursing shifts that required standing, walking, and physical stamina that became impossible when the pain flared. As a labor and delivery nurse, I was familiar with pain management and reproductive health issues, and I knew that what I was experiencing was not normal menstrual discomfort, but something that required medical investigation and treatment. My first consultation was with Dr. Robert Mitchell, a gynecologist in my insurance network who had been recommended by colleagues as competent and thorough. I provided detailed descriptions of my symptoms, including pain location, intensity, timing, and impact on my daily functioning, expecting the comprehensive evaluation that I would have insisted on for any patient presenting with similar complaints. Instead, Dr. Mitchell performed a brief pelvic exam, asked a few cursory questions about my menstrual history, and concluded that I was experiencing normal variations in menstrual pain that could be managed with over-the-counter pain medications and heating pads. When I explained that I was a healthcare professional who understood normal menstrual discomfort, and that my symptoms were significantly more severe and disruptive than anything that could be considered normal, Dr. Mitchell's demeanor shifted from professional courtesy to barely concealed irritation. He suggested that my medical training might be making me overly anxious about routine symptoms, and that healthcare workers sometimes had difficulty distinguishing between their professional knowledge and their personal medical experiences. His dismissal felt both patronizing and racially coded, as if my concerns were inherently less credible because of assumptions about my pain tolerance, emotional stability, or tendency toward hypochondria. The pattern of dismissal and minimization continued through multiple medical consultations over the following months as my symptoms worsened and began affecting every aspect of my personal and professional life. Emergency room visits during particularly severe pain episodes resulted in cursory examinations, drug screenings to rule out drug-seeking behavior, and discharge instructions for acetaminophen and rest. When I requested imaging studies or referrals to specialists who could investigate potential causes of my symptoms, emergency physicians would note in my medical records that I appeared anxious about minor discomfort and was requesting unnecessary tests for conditions that they deemed unlikely based on brief evaluations. The most devastating dismissal occurred during an emergency room visit when the pain had become so severe that I couldn't stand upright or drive myself to the hospital. My friend and fellow nurse Angela Rodriguez brought me to the ER where I was triaged as non-urgent despite presenting with severe abdominal pain, nausea, and vital signs indicating significant distress. Dr. Jennifer Walsh, the attending physician, spent less than 5 minutes examining me before concluding that I was experiencing menstrual cramps that didn't warrant extensive evaluation or pain management beyond what I could purchase over the counter. When I attempted to advocate for more thorough evaluation by explaining my medical background and describing how my symptoms differed from normal menstrual pain, Dr. Walsh interrupted me to say that patients with medical training often overestimate the severity of routine symptoms and that my nursing experience was making me unnecessarily worried about normal reproductive function. Her tone and body language conveyed clear skepticism about my reported pain levels, and she made a point of noting in my medical records that I was requesting narcotic pain medication, despite the fact that I had never asked for specific medications but had simply requested appropriate pain management for severe symptoms. The professional consequences of my untreated medical condition began affecting my nursing career, as the pain made it increasingly difficult to perform physical aspects of my job that required standing for long periods, lifting patients, and maintaining the energy and focus necessary for safe patient care. I was forced to use sick leave frequently, request schedule modifications that accommodated my symptoms, and eventually consider whether I could continue working in labor and delivery, where the physical demands were incompatible with my deteriorating health condition. The psychological impact of having my pain consistently dismissed and minimized by medical professionals was almost as devastating as the physical symptoms themselves. I began questioning my own perceptions and wondering whether I was somehow overreacting to symptoms that weren't as severe as I believed. The gaslighting effect of repeated medical dismissal created self-doubt that interfered with my ability to advocate effectively for my own healthcare needs, leading me to accept inadequate treatment and delay seeking additional medical opinions that might have provided earlier diagnosis and intervention. The turning point came during a particularly severe pain episode that resulted in my collapse at work while caring for a laboring patient. My colleague Angela immediately recognized that I was experiencing a medical emergency and insisted on calling an ambulance despite my protests that I would be fine with rest. The paramedics who responded found me in severe distress, with vital signs indicating significant physiological stress, and they transported me to Memorial Hermann Hospital, where I would encounter medical bias so extreme that it nearly resulted in my death. The emergency department evaluation at Memorial Hermann followed the same pattern of dismissal and minimization that had characterized my previous medical encounters, but with additional elements of discrimination that reflected both racial and gender bias in pain assessment and treatment decisions. Dr. Marcus Thompson, the attending physician, spent minimal time examining me before concluding that I was experiencing typical menstrual pain that didn't warrant imaging studies or specialist consultation. When I explained that I was a nurse who understood the difference between normal and abnormal symptoms, he responded by suggesting that healthcare workers were notoriously bad patients who tended to be dramatic about routine medical issues. The discrimination became more explicit when Dr. Thompson noted in my medical records that I was demanding specific tests and pain medications, characterizations that bore no resemblance to my actual behavior but reflected stereotypes about Black women being aggressive, drug-seeking, and manipulative in medical settings. His documentation included phrases like appears to be exaggerating symptoms, requesting unnecessary interventions, and showing drug-seeking behavior that would follow me to future medical encounters and prejudice other providers against taking my symptoms seriously. The life-threatening crisis occurred 6 hours after my arrival at Memorial Hermann, when my untreated endometriosis caused an ovarian cyst to rupture, resulting in internal bleeding that required emergency surgery to prevent hemorrhagic shock and death. The surgical team discovered extensive endometriosis that had been growing untreated for years, causing adhesions and organ damage that could have been prevented with earlier diagnosis and treatment. The surgeon, Dr. Patricia Williams, was appalled by the medical records documenting years of dismissed symptoms and inadequate evaluation for obvious gynecological pathology. The recovery period was complicated by the extent of damage that had occurred during years of untreated endometriosis, requiring multiple surgical procedures to remove adhesions and repair organ damage that had resulted from delayed treatment. Dr. Williams explained that the severity of my condition suggested years of progressive disease that should have been diagnosed much earlier with appropriate gynecological evaluation and imaging studies that had been repeatedly denied or delayed by physicians who dismissed my symptoms. The fertility impact was devastating, as the years of untreated endometriosis had caused scarring and organ damage that significantly reduced my chances of conceiving and carrying a pregnancy to term. As a labor and delivery nurse who had dedicated her career to helping women become mothers, learning that medical bias had cost me my own reproductive potential was emotionally crushing and professionally heartbreaking in ways that extended far beyond the physical trauma of my emergency surgery and recovery. The legal consultation that followed my emergency surgery revealed that my experience was part of a documented pattern of medical bias affecting Black women's healthcare outcomes, including higher maternal mortality rates, delayed diagnoses of serious conditions, and systematic undertreatment of pain that results in preventable morbidity and mortality. Attorney Denise Johnson, who specialized in medical malpractice cases involving racial bias, explained that my case included multiple instances of medical negligence that could have been prevented with appropriate standard of care. The medical malpractice lawsuit took 3 years to resolve but ultimately resulted in settlements with multiple providers who had failed to provide appropriate evaluation and treatment for my symptoms. The legal process required extensive documentation of discriminatory treatment, expert testimony about standards of care that had been violated, and evidence of the long-term consequences that resulted from delayed diagnosis and treatment. The settlements provided financial compensation for medical expenses, lost wages, and pain and suffering, but couldn't restore my fertility or undo the years of unnecessary suffering. The advocacy work that emerged from my healthcare discrimination experience has become a central part of my professional identity and community involvement. I now work with organizations like the Black Women's Health Imperative and the National Medical Association to educate healthcare providers about racial bias in pain assessment and treatment, advocate for policy changes that improve healthcare equity, and support other women who have experienced medical discrimination. The education component of my advocacy includes speaking at medical conferences, nursing schools, and hospital staff meetings about the reality of racial bias in healthcare and the specific ways that stereotypes about Black women affect clinical decision-making and patient outcomes. Many healthcare providers are genuinely surprised to learn about documented disparities in pain treatment and reproductive health care, and education can change practice patterns while also creating allies who support healthcare equity initiatives. The policy work has focused on implementing bias training requirements for healthcare providers, establishing patient advocacy programs that help minorities navigate medical systems, and creating accountability mechanisms for providers and institutions that demonstrate patterns of discriminatory treatment. The goal is systemic change that addresses both individual provider bias and institutional practices that perpetuate healthcare inequities. Today, I work as a patient advocate at Memorial Hermann Hospital, the same institution where I nearly died from medical neglect, helping to implement changes in emergency department protocols, pain assessment procedures, and provider training that can prevent other patients from experiencing the discrimination and delayed treatment that characterize my own medical care. The irony of working to fix the system that failed me isn't lost on me, but it provides an opportunity to create change from within while supporting other patients who face similar challenges. The reproductive health advocacy has become particularly important as I work with organizations focused on Black maternal mortality and reproductive justice. My experience as both a labor and delivery nurse and a victim of reproductive healthcare discrimination provides unique perspective on the systemic issues that affect Black women's reproductive outcomes and the changes needed to ensure equitable healthcare access and treatment. Key resources and solutions that made the difference. The Black Women's Health Imperative provides advocacy, education, and policy work focused on eliminating health disparities affecting Black women, including reproductive health discrimination and pain bias. Patient advocacy services at hospitals and healthcare systems help patients navigate medical care, document concerns about treatment quality, and ensure that their voices are heard in clinical decision-making processes. Medical civil rights organizations like the Lawyers Committee for Civil Rights provide legal representation for victims of healthcare discrimination and work on policy reforms to address systemic bias in medical care. Bias training programs for healthcare providers address racial stereotypes in pain assessment, reproductive health, and clinical decision-making that affect patient outcomes and treatment quality. Second opinion services and patient navigation programs help minorities access appropriate specialist care and comprehensive evaluations when primary providers dismiss or minimize their symptoms. Healthcare equity organizations work on policy changes, provider education, and institutional accountability measures that can reduce discriminatory treatment and improve health outcomes for minority patients. Emergency department reform initiatives focus on improving triage procedures, pain assessment protocols, and provider training to ensure equitable treatment for all patients regardless of race or background. Reproductive justice organizations advocate for equitable access to reproductive health care, address disparities in maternal mortality, and work to eliminate bias in gynecological and obstetric care. Today, When I meet other minorities who have experienced medical discrimination or feel that their pain isn't being taken seriously, I tell them to trust their instincts, document everything, and persist in advocating for appropriate medical care even when providers dismiss their concerns. Your pain is real, your symptoms matter, and you deserve the same quality of medical care that would be provided to any other patient. Medical bias is documented and systemic, but there are legal remedies and advocacy organizations that can help you fight for the healthcare you deserve. Don't let anyone convince you that your suffering is normal or acceptable when you know something is wrong.